Hello and welcome to lecture. My name is Dr. Andrew Craig, and the topic for today's lecture will be the knee joint and outcome measures. Uh, you'll notice this one plays off nicely from the hip joint lecture, which was our most recent lecture. And the reason for that is a lot of the same rehab principles that apply to the hip also apply at the knee. A lot of the largest musculature in the body passes over the hip, and it essentially applies its force and applies uh, its end effect on the knee. So things like the quads, the hamstrings, the IT band, all of that crosses over the hip, but also crosses over the knee. So um, because we have so many cyclical movement patterns that we do in a day, walking, jumping, running, those sorts of things, we need to generate force at the knee and we need to generate force at the hip, but we also need to generate it at the knee. So there is a lot of common conditions that can affect the hip and the knee. A great example is the hip and the knee are the two most common reasons for joint replacements because of arthritic changes. That's just because we are constantly loading our hip and our knee, and so they're prone to those load-bearing injuries. And so a lot of the rehab principles are very similar between the two. So it kind of plays nicely off of that. The way that I've structured the course is that we discuss the hip in the first half and then the knee in the second half. That's simply for kind of sharing the volume of work. There's a lot of information in this lecture. There's a lot of information in the hip, and so it's easier to sort of parse it separately, test you on the hip, and then test you on the knee separately. It's also it's good to give you a bit of a break when thinking about the hip, and then come back to it with the knee. So it's a great lecture. Lots of people have created full careers just working on the hip and knee, and so it's a huge area of rehab if you're interested. The game plan for today is the same as every other lecture. We're going to talk about some anatomy. We'll probably take a little bit of extra time throughout this lecture to actually review the anatomy because there's a lot of clinically relevant structures in terms of ligaments at play and some very unique structures like the meniscus, the ACL, the PCL. So we're going to take a bit of time to go over a number of the structures. We'll talk about some common conditions like injuries to all of those ligaments, um, patellar tendinopathy, some bursitis, those sorts of things. So there's a number of conditions. Then we'll talk about rehab. We'll talk about rehab specifically focused probably on a couple of areas like the ACL. There's lots of well-known rehab protocol for surgical and non-surgical care for ACL and PCL injuries. So we'll talk about that. And then we'll talk about an outcome measure. We'll talk about the KUS specifically, which is specific to the knee, but you can also use the LEFS, which is the lower extremity functional scale, which I introduced you to through the hip lecture. It's actually it's reliable and valid for any sort of lower limb injury, whether it's the hip, knee, ankle, or anything like that.
The knee is interesting. We think of it just as this simple hinge joint, but it's actually highly dynamic and there's lots of things going on in the knee. It's an area of high force transmission. We put, uh, you know, 10 times the amount of force through our knee as our body weight. So it does take a lot of load every time we take a step, especially when going up or down stairs or when we're running. So there are two distinct articulations within the knee joint capsule. You've got the tibiofemoral joint, so the joint between the tibia and the femur, which is the primary joint people think of. Then you've got the patellofemoral joint. So the patella, as it glides along the groove, um, along the femur. Okay. Typically, or technically, sorry, the superior tibiofibular joint is not contained within the knee joint capsule. And it's actually more functionally related to ankle movement than it is to the knee movement. So it does have some contributing aspects to the knee. The LCL does attach to the fibula, but in reality, when we're assessing biomechanics or functional abilities, the superior tibiofibular joint is actually more related to ankle function than anything. So it's not actually part of the knee complex from a technical perspective. This image, actually, you can see within this image how the superior tibia fibular joint is not contained within that knee complex, and it's actually quite a bit outside. But you can also see that the patella is associated with the femur primarily. So the patella moves up and down as our knee flexes and extends. A lot of that musculature goes from the hip down into sometimes into the patella. Posteriorly, it doesn't go into the patella, of course, but it crosses over the knee joint, or sorry, the knee articulation, and attaches into the tibia for the most part. On the right side, we can see how that fibula actually only articulates with the tibia superiorly and inferiorly, and the fibula actually comes down and makes that lateral styloid on the ankle, which is where if the talus moves or the ankle moves, it actually will drive the fibula into different positions, which can impact that superior articulating surface. The term arthrokinematics, if we break it up, arthro means the joint, okay? Kinematics means the quality of movement. So it's essentially looking at, or it's a description of the quality of movement of a joint. Okay, we look at if anybody's interested in sort of airplane mechanics and air air dynamics. We look at yaw, pitch, and roll. Okay, so yaw is this rotation around the vertical axis. Pitch is this rotation around the horizontal. And then roll is this rotation around the anterior to posterior axis. When we talk about the arthrokinematics of a joint, we talk about three different types of movement as well. So we've got roll, glide, and spin, and they all happen at the knee joint. Okay. In order to sort of conceptualize this in your brain, think of a roll as in what we're going to use as a comparison is a rock on top of a hard surface. Okay, so roll is if you can push that rock and roll it off of the surface. So you've got multiple points on that rock will actually contact multiple points on that surface as it rolls off. Okay, so think of a circular rock. Glide is kind of analogous with slide. So if you have a square rock, you're not going to be able to roll it. You're actually just going to have to slide it or push it. So you've got single point on one surface, that would be the rock you're pushing, contacts multiple points on another surface. Okay. Spin, on the other hand, is almost like a top spinning. So one point on that surface is actually spinning just on one point of the other surface. So if we're looking at the knee joint in particular, roll is that actual, when we have that flexion and extension movement, that would be sort of the roll of the knee joint. The glide would be anterior translation of, say, the tibia on the femur, or the femur on the tibia. So the ACL and the PCL restrict that gliding movement. And then spin is if you have your foot planted and you rotate, you'll see that if your foot's planted, the tibia will stay in place and the femur will actually rotate on top of it, or spin. Okay, so I want you to know the difference between roll, glide, and spin. The patella is this really interesting bone. It's the largest sesamoid bone in the body, and its primary purpose is to provide mechanical advantage to the quadriceps tendon. Okay, so it makes the quadriceps job a little bit easier, given how much force it needs to provide to allow you to move within space. Okay, so how does the patella really provide that mechanical advantage? I'm assuming that you've probably talked about this in other classes, but what it does is it essentially increases the moment arm from the center of the joint to the tendon. Okay, so without a patella, here's the femur, here's the tibia. Without a patella, the tendon slides very, very close to the joint center. The patella, when it's present, actually displaces that force vector, and it actually changes the angle of that force vector as well. So you can see here, it's a bit on a sloped angle, whereas here it's a flat angle. Both of those factors, the fact that it changes the directional force vector, but it also changes the moment arm, allow an improvement in the mechanical advantage of the quadriceps tendon to apply an extension ability to the knee joint. Okay, so I want you to remember those two things. It changes the length of the moment arm, and it changes the angle at which that force vector is applied to the knee. Okay, so the force vector is shown in the image below, and the moment arm is demonstrated on the image above. Now the knee joints, at the distal end of the femur, you've got these two prominences, or the femoral condyles, and they're these spherical prominences that that allow for movement or smooth movement on the tibial plateau. So they're very, very, very smooth joint surfaces, and they are spherical. The tibial plateau, on the other hand, is very flat. So it's kind of like this picture on the bottom left here, with a ball on a flat surface, which isn't the greatest articulating surface. So there's incongruence between the femoral condyle and the tibial plateau, or where it meets the tibia. So how does our body sort of adjust for this, or improve the congruence between those two surfaces? This is where the meniscus comes in handy. So you've got essentially two of these concave meniscus surfaces that allow for enhanced congruence between the femur and the tibia. So you've got one meniscus on the medial aspect and one meniscus on the lateral aspect. It just improves the surface contact, and also improves the depth of that joint surface. And inherently, it allows for some shock absorption, given that you put, say, anywhere between 10 and 20 times your body weight through your knee if you're doing any sort of plyometrics or going up or down stairs. So again, the meniscus is it's an asymmetrical fibrocartilage disc, and you have one on the medial and the lateral aspect. Okay, so you have one for each femoral condyle. They both open up towards the center. Okay, so they're highly protective of the lateral aspect of the knee joint. And typically they are thick peripherally and thin centrally. So as they come to the middle, they get a little bit thinner. The horns are these areas here at the end of the meniscus, where it attaches to the tibial prominence here in the middle. Okay. They really do create this nice little sling for the femoral condyles to be able to maneuver in. They act as shock absorbers. They also help to improve circulation of the synovial fluid, and which helps to sort of nourish the joint. So what are the functions of the meniscus? I would like you to know this. First off, they deepen the articulation. Okay, so they allow for improved congruence between the femoral condyle and the tibia. They increase the contact area between the femoral condyle and the tibia, which allows for consistent force to be placed over a larger distance or a larger area, which reduces any sort of point forces or single forces to one point on either joint surface. It also allows for increased shock absorption for when you're doing high impact activities like jumping, running up and down stairs, any sort of contact sports, or change in directional sports. It increases the stability of the knee, so it's not. It does that through that increased area of contact. And the meniscus also helps to circulate synovial fluid around the joint, and this allows for improved nutrition to the joint surfaces, because the joint surfaces actually have very poor blood supply, and they get most of their nutrients through a process called imbibition, which is where the fluid circulates around, and it brings nourishing substances to the area, but it also cleans the area of any sort of waste products that might be present. Although you have a medial and a lateral meniscus, they are structurally a little bit different. Actually, quite a bit different. So the medial meniscus, which I'm indicating here with my cursor, it's got this large C, very wide and broad shape to it. It's quite stably, it's attached quite stably to the tibia. It's also attached to the MCL, the joint capsule, and the semimembranosus. Okay, so it stays in place, and this one is pretty well your load bearing meniscus or your load bearing aspect of the joint. Okay, a lot of the load happens here. The lateral meniscus, on the other hand, it is almost a circle. It's almost like a fully confined circle. It's smaller and it's actually more mobile, so it doesn't take as much load as the medial meniscus. And if you're standing on a planted foot and you pivot, you will notice there's a little bit of rotation that happens at the knee. Typically, the medial meniscus stays in place because it's stable and it's attached to so many structures, whereas the lateral meniscus actually has more mobility. So it will move and it will allow the femoral condyle to sort of rotate and transition on top of the tibia, which is helpful from a movement perspective. Okay. It is attached to some other tissues. It does attach to the PCL, which isn't represented on this slide, but it's also attached to the popliteus muscle. The popliteus muscle is very interesting. It's you may not have heard of it, but it's a small muscle at the back or the posterior aspect of your knee, and it's responsible for hinging and unhinging the knee joint. So clinically, if individuals have issues with the hinging and unhinging of their knee, I will always look towards their popliteus and their lateral meniscus to see if there's any issues there. The meniscus is a structure that bears a lot of weight and a lot of load, so it is prone to tears, and you can have little tears in different areas of the meniscus. In my experience, typically that medial meniscus is getting more damage done to it just because it does accept more of the load. But you can get something called a bucket handle tear. You can get partial tears, full thickness tears. I've seen it all on MRI reports from a meniscus standpoint. Many of the muscles that we learned earlier this week in the hip lecture, they do apply across the knee as well, right? You've got the quadriceps, which come down and attach to the patella, which exert most of their force at the hip, but also at the knee. You've got the hamstrings on the reverse side, which also come down and attach from the hip. They cross the hip and they cross the knee, so they're multi-joint muscles. But you should be familiar with them from a global perspective. I'm just going to touch on a few things that I want to make sure that you understand. So again, the quadriceps and the hamstrings, they cross the hip and the knee, so they are two joint muscles or double joint muscles for that matter. Quadriceps obviously flex the hip and extend the knee. The hamstrings flex the knee and extend the hip. So they basically work in opposition to each other, the quadriceps and the hamstrings. The popliteus, again, it's that unlocking mechanism. So if we look in the top right here, I've included an image just from that I found on the web. The popliteus, when it contracts, it will cause slight flexion of the knee joint, but it also causes this rotation, this lateral bending or lateral rotation of the femur, which allows for that unlocking mechanism. The pes anserine is the name. Pes anserine literally stands for the goose's foot. I'm not quite sure what language that is in, but it's this structure on the medial aspect of the knee. And it's called that because it literally looks like a goose's foot. It's the collection of three specific tendons, the sartorius, the gracilis, and the semitendinosus. Okay. All of those tendons at their distal attachment come into the medial aspect of the knee, and they attach at the site of the pes anserine. This area can become, you can get tendonitis at this area. We call it pes anserinitis. You can also get a bursa flare up. We're going to talk about bursitis in a few slides, but a bursa is essentially a fluid filled sac that reduces friction and inflammation at areas of high friction and inflammation. So if you think about somebody who does a lot of running or puts a lot of miles in on their feet, they're constantly flipping, they're constantly utilizing their sartorius gracilis semitendinosus, which puts a lot of stress to this area and can cause either friction at the knee joint, friction at the pes anserine bursitis, or tendonitis if it's an overuse issue. If we look lower than the knee, you've got the gastrocnemius, which crosses the knee joint as well. So its distal attachment is the calcaneus, comes up through the Achilles tendon, and then attaches to the posterior aspect of the femoral condyles on either side. So you've got two primary bellies. So it does cross the knee joint, okay? The soleus, which is the other muscle, primary muscle that makes up the calf, does not cross the knee joint. Okay, so it doesn't really have a huge impact on knee kinematics. The knee joint has a very complex, intricate, and in my opinion, very interesting ligamentous system. Okay, lots of forces are going through the knee that either passive or active. And so you need a lot of ligaments to create stability, and they need to create stability by limiting movements that we don't want. Okay, so a lot of that if we boil it down to its fundamental task, ligaments are there to prevent excess movement in a direction that we don't want that joint to move in. Okay, so we're looking at limiting excess knee extension, valgus and varus with the collateral ligaments, anterior posterior shear with the cruciate ligaments, and medial lateral rotation also with the cruciate ligaments and those menisci. Apologies. So we're going to talk about each of these ligaments sort of one at a time, and then we'll go through a couple of cases that examine how these ligaments can be injured. We'll start with the MCL, or the medial collateral ligament, which tells you exactly where it is. So it's on the medial aspect of the knee. Collateral, meaning there's one on either side. You've got the MCL and you've got the LCL. And so the MCL it exists on that medial aspect of the knee. Okay, so it stabilizes any sort of valgus stresses, or resists any valgus stresses or knock knee. And this is true, especially when the knee is extended, because that's when the ligament is most tight. It is almost like a thin, broad piece of paper that lays directly over top of the medial aspect of the knee. If somebody is to injure ligaments in the knee, I often say the MCL is the better of the two. That's because it actually has very good blood supply, and it's less common to fully tear your MCL because it does have that very broad, thin paper-like structure. It usually has a partial tear, and since it has better blood supply than the LCL, it usually heals a little bit more readily, and it's usually the rehab is a little bit more effective for the MCL. The LCL, or the fibular collateral ligament, is on the lateral side of the knee, of course. And it goes from the lateral femur to the lateral aspect of the fibular head. It does not attach to the meniscus, which, if you remember a few slides ago, I said that the MCL did. And the structure is very different than the MCL. The MCL is that paper-like flat structure. The LCL is more of a rope-like structure. It's very, very, it's thicker, and it's almost like a rope or like a pencil. Okay, a lot of times you can palpate it if you just feel the lateral aspect of your knee and apply a slight valg or varus force. You will get that LCL popping out into your hand. Okay, it's, in my opinion, it is worse to actually tear the LCL. First off, it's more prone to full tears because it is a less broad tendon, and it has poorer blood supply, so it doesn't heal as well. So it's much more prone to full tears because of those things. The primary role of the LCL is to resist varus forces. Uh, and it is usually, yeah, it is the one that typically will tear fully, I find. And it's very, very obvious when you look at it from an orthopedic perspective. When you actually grab someone's knee, apply a bit of a varus force, you might do what we call a figure 4 test, and you'll notice that the LCL, there's some laxity in the knee in those tests. The ACL and the PCL, so the anterior cruciate ligament and the posterior cruciate ligament. Okay. Remember, I said when we talked about the cervical spine, whenever a ligament's called cruciate, it's because it crosses with something. Okay. Anterior cruciate ligament, so it's the crossing ligament on the front. PCL is the crossing ligament on the back. Okay. And there's a nice way to sort of figure this out. And I've put a picture on the slides. Maybe we'll talk about this during lecture. But if you cross your fingers and you overlay them on top of your kneecaps, that will show you how those ligaments lay. So the ACL is your middle finger and the PCL is your index finger. These ligaments are quite neat because they are intracapsular, meaning that they're combined within the capsule of the knee joint. So they're sort of bathed within that synovial fluid, and they aren't palpable. You can't touch them. The MCL and the LCL, you can actually physically touch. So the LCL would be over here, and you could physically feel if it's there. The MCL, it's more of a broad ligament, so you won't really feel if it's there, but you will be able to recognize overt swelling, redness, and that sort of thing. So the ACL, it's obviously in the front aspect or the anterior aspect of this ligament complex, and it runs from the posterior lateral condyle of the femur to the anterior tibia. Okay, the primary function is to prevent anterior displacement of the tibia on the femur. So if you're sitting there on your computer and you want to Google anterior drawer test and Lockman's test, those are the typical tests to examine if the ACL is injured. And so those tests, what they do is you basically grab onto or stabilize or fix your hand, your lower hand on the tibia, you stabilize the femur, and you draw the tibia forwards to see if there's any laxity. If there's laxity, that means that the ACL's potentially compromised. Most typical mechanism of injury, that's what MOI stands for, is in my experience, it's non-contact injuries. So let's say a soccer player planting and pivoting. So they've planted with their knee in that like 30 degrees of flexion, and then they're pivoting. So they're rotating their femur on their tibia in a very forceful manner. And that's enough usually to tear the ACL. The PCL, it runs from the anterior medial condyle of the femur to the posterior tibia and lateral meniscus. Okay. It prevents the exact opposite to the ACL. So it prevents posterior translation of the tibia in relation to the femur. Okay. The injury mechanism for this is very specific. I've only seen it in 2 scenarios. I've seen it with hockey injuries where a player goes into the boards with their knee and their hip flexed. And typically what happens is where the boards and the glass meet, that creates a ledge. If their tibia, so let's say their femur is just above that ledge and their tibia impacts the boards, what happens is their femur is translated very far anteriorly in relation to the tibia, and this is enough of a stress to actually tear that PCL. The other time I've seen this happen is in a car accident, if somebody has their knee up on the dashboard in the passenger seat, and that force will force the tibia directly posteriorly and apply stress to that PCL. We're going to talk about these. There's a couple of rehab characteristics that I want to highlight in a few slides. So we will come back to these structures. I just want to get through all the anatomical considerations first. The infamous IT band or the iliotibial band. Okay. The IT band is a very fancy name for just a thick, dense, fibrous connective tissue structure that goes down the lateral aspect of the thigh. So it goes from the hip all the way down past the knee and supports both the hip joint and the knee joint. The primary, actually, let's back up. Since it is fibrous, there are no contractile components to the IT band. Okay, so it's just a connective tissue structure. The reason it can get quote unquote tight or there's lots of forces going through the IT band is because of the muscles that attach into it. So you've got the gluteal components, the gluteus maximus, the tensor fascia lata. You've got some contributing fibers from some of the hamstrings and the quadriceps. They're all putting forces in different directions on the IT band for the purposes of transmitting those forces from the large, robust muscular system of the hip down and across the knee. It is constantly tight. So people roll this out, people do work to the IT band, but in a rehab perspective, you can roll it out. It does help, feels good. Sometimes you can get some loosening of the tension in the IT band, but you really do have to address the muscles that are putting too many stresses onto the IT band. So you have to work on the tensor fascia lata, the gluteus medius, in order to reduce strain to the IT band. Again, the IT band stabilizes the hip, it also stabilizes the knee, and it creates this nice little sling behind the knee and the lateral femoral condyle with the biceps femoris and the vastus lateralis, and it actually supports the ACL, especially when the knee is flexed. So when the knee is flexed, the IT band will sort of support the ACL and prevent any sort of ACL damage to a certain degree. Potentially, you've heard the term bursitis. And bursitis, if we split that word up, bursa, itis. Remember, I said this multiple times throughout the course. Itis means inflammation. So it means inflammation of the bursa. Bursas are all over your body, okay? They are essentially fluid-filled sacs full of synovial fluid, which lubricates joints, but it also lubricates high friction areas. Areas where there are a lot of tendons going over, areas of high repetition of movement, any of those things, you're going to have bursas. So the knee has a number of bursas, the shoulder, the hip, anything with a lot of mobility is going to have bursas. Now, what can happen is you can get inflammation within these bursas if there's too much movement happening or if there's odd compression forces that are happening. And within the knee, you've got a number of different bursas that can inflame. We've already talked about the pes anserine bursa, pes anserine bursitis. You can have infrapatellar, you can have prepatellar, suprapatellar. There's a number of bursas that can become inflamed. Bursitis, clinically, when you see it, a lot of times it feels like a burning sensation. It's usually aggravated after repetitive motions. Ice feels fantastic. It can help to sort of reduce inflammation if there is an excessive amount of inflammation in the area. And a lot of times from a rehab perspective, you're going to maybe change up their training strategy. Maybe there's too much repetition or volume. You might be changing the actual variety of exercises that they're doing so that you're not loading the same bursts constantly as well. So at the end of the day, your knee joint functions to transmit forces from the ground to your body and vice versa, from your body to the ground. So the primary motion that we think of is flexion and extension. It's also got some medial and lateral rotation to it. We want to try to limit varus and valgus forces. And also we want to limit anterior posterior and posterior anterior translation of the tibia on the femur, because we want the knee to be stable in those directional forces so that we can achieve these primary motions effectively. Okay. The nice thing about when you are assessing any sort of peripheral joint, whether it be the wrist, the knee, the elbow, the shoulder, you've got two, right? For the most part, you can compare side to side. So you can always compare left to right. And if you're concerned that there's laxity in one side, you can always compare the opposite side. And if you're working with athletes or clients who may have amputations or may not have uh, the opposite limb, or this is also true for anybody who has severe atrophy, so geriatric populations or patients who have had strokes, you can always look at general mobility. Okay, so you want to know if somebody's hypermobile, hypomobile. If you're assessing a knee on somebody who has an amputation to the other side, and you're like, oh wow, this looks like there might be some laxity in the ACL, you can always refer them to a medical provider who can send for imaging to confirm or refute that finding. You can also do a very quick screen of their other joints of their body to see if there's general laxity throughout the entire body, because sometimes that is the case. Okay, so this next section of the lecture, we're going to talk about some common conditions that you're going to come across in the knee. And here's a whole list. This is not an exhaustive list of knee injuries, but this is sort of, when I put my brain to it, this is the most common, these would be the most common things that you'll see clinically. So you got ligament injuries, meniscal injuries, knee bursitis, strains and sprains, the unhappy triad, which is an injury to the ACL, the MCL, and the medial meniscus. Anybody who I've seen clinically with an unhappy triad of these three passive structures being torn, they have surgery. So they're typically entered into post-surgical care right away. You've got injuries like patellofemoral pain syndrome, which we'll discuss, patellar tendinopathy, which can be a nightmare to rehab. I actually deal with this myself. And then you can have other injuries, childhood disease like Osgood-Schlatter's. You can have chondromalacia patella, which we'll discuss, and then obviously knee fractures, arthritis, and dislocations. In general, this is here in the knee lecture, but this is sort of important for all rehab. Okay, when we are considering what exercises to prescribe, what volume to prescribe them at, whether they should be supervised, unsupervised, whatever you're considering in your rehab program, you need to think of these aspects. What is the severity of their injury? This is going to tell you where can we start with rehab, um, and what biomechanically would we expect them to be able to achieve. Okay. You need to consider what is their previous experience with exercise and activity. Are they highly active? Were they previously highly active and are going to be familiar with exercises, but probably are going to get frustrated with their abilities in those exercises? You need to think about what kind of equipment and resources you have available. What is the individual's motivation? Was it a workplace injury? Was it a motor vehicle accident? Do they have an Ironman coming up that they're looking toward or looking forward to? Do you find that they're going to be compliant? Can you trust that they're going to do their exercises at home? Do they have multiple providers? Are you going to be in a collaborative care setting where you're dealing with a physiotherapist and their family doctor? Is there athletic therapists at the school and the sports team that they're working with? Is there a sport or activity that they need to have in mind? If they're a tennis player, you're going to be dealing with a lot of medial and lateral movement. So ligamentous stability is of utmost importance in the knees. And then what's their support system like? Do they have a significant other, parents, family members that they can kind of lean on for emotional and social support? So all of these things are very important for all types of rehab. Let's look at our first knee case for the day. Okay, so we've got a 45-year-old female with anterior right knee pain. She doesn't really know why it happened. It's been bugging her for the last few months, and it's mostly bothersome when she climbs stairs. Right? She also noticed when she's at the movies or at work, she gets pain after sitting for a long period when her knees flex. Okay. You did an assessment and you ruled out any sort of gross anatomical pathologies. So we're talking major tears, uh, major tears, any growths. But you do notice that there is some redness, swelling, bruising. And she went to her family doctor who gave her a prescription that says that they have patellofemoral pain syndrome on the right side. The individual is rather sedentary. They don't have much experience with exercise, but they have been trying to sort of change their ways a little bit, and they've been walking the stairs more frequently. Okay, so there's your details for the case. Since we know it's patellofemoral pain syndrome, you're going to have to turn to the literature, do some research, or what you already know about this in terms of what you're going to do for rehab. So patellofemoral pain syndrome, or PFPS, as I'll call it for short. Typically, this presents as anterior knee pain around and encapsulating the patella. Okay, it's kind of like an angry knee. Oftentimes, it's a tracking issue in the knee. So over the next slide, I'll show you what a tracking issue is. But essentially, as you contract and relax the quadriceps, you get the kneecap will glide superiorly and inferiorly. If it's not gliding properly, it can cause some friction in that area and cause some patellofemoral pain. Okay, so some pain between the kneecap and the femur. Typical causes, again, poor patellar alignment or tracking. So you're going to have imbalances in the vastus medialis, or any of the quadriceps for that matter. You can have abnormal stresses on the patella because of hamstring imbalances or quadricep imbalances. So if your quadriceps are incredibly strong and your hamstring is weak, then you're going to have some imbalances on how that patella is being tugged on. You can also be predisposed to PFPS if you have a increased Q angle. So a Q angle is this angle between the femoral head and the tibia. Okay. If this Q angle is very large, it puts very odd forces onto the patella. So the patella doesn't track as much in line with the femur. Okay. This is what we call a sunrise view of the knee. And you can see that the patella sits very nicely within that femoral condyle. Okay, so this is the femur. And this is as if you were, if you're sitting at your desk right now, if you look down at your knee, this is almost that exact view. So you're looking at the patella sitting nicely in that groove. Patellar tracking, if we have a normal orientation. So here is the patella in relation to the femur. If we have normal orientation with that sunrise view, you can see that they're nicely lined up. So the patella is nicely in the middle of that groove. If you have what's called lateral patellar glide, you can see it's kind of laterally deviated to the left. If this is gliding up and down, sort of up and down over top of the femur, it's going to cause some friction between those two surfaces. That's going to cause some pain. This can cause PFPS. This can also cause some chondromalacia patella. You can also get a situation where there is lateral tilt, which also sort of changes the quote unquote alignment of the patella and the femur. And this can cause some irritation to the patella and femoral surfaces as well. When you're assessing somebody from a static posture, you're going to look at the orientation of the patella as well. So is there lateral rotation, medial rotation? Is it sitting in a weird position? So throughout your assessment, you're going to look at this, and there's all sorts of exercise rehab that you can provide to try to encourage the kneecap to track properly. You can also use some taping strategies to try to improve that tracking. And you'll see with this KINE tape here, they've got essentially what I call a sling tape job around the kneecap to encourage that kneecap to track in one plane. So if the person's knee looked like this without tape, that tape is theoretically going to improve that knee tracking ability. So just one thing I want to backtrack and talk about is that Q angle. Okay. So the Q angle, for lack of a better description, or sort of the definition of the Q angle, it's defined as the angle that's formed between the intersecting lines drawn from the ASIS to the center of the patella. That's the first line. The second line goes from the center of the patella to the tibial tubercle on the tibia. Okay. And then you measure the angle in between there. Now, a normal angle for the Q angle in men is 10 degrees, and in women, it's 15 degrees. And this is because of anatomical differences within the pelvic girdle between men and women. You can measure this while they're standing up, you can measure it while they're lying down. And if they're outside of these numbers, then it can change the sort of biomechanical advantage of the quadriceps on the knee. When we do rehab for PFPS, we need to strengthen and even out the strength that surrounds the knee joint, and it often involves multiple muscle groups on the anterior aspect, posterior aspect, and everything in between. Okay, so we're looking at strengthening the quadriceps, the hamstrings, probably the popliteus, the gastrocnemius, everything that we can to try to improve the tracking of that patella. A lot of people will focus just on the quadriceps because that is what is pulling on the patella. However, any sort of deviation in the forces around the knee will cause sort of improper alignment of the patella over top of the femur, and it can cause issues with PFPS. Okay, so here's a number of exercises that I've used with success with PFPS, and so you've got active straight leg raise, which can help to, you can do this slowly, you can do this fast, you can change the speed, you can put a weight on the foot, you can actually internally or externally rotate the foot to try to selectively target the medial or the lateral quadriceps. And it's nice because it puts the patella under constant load. Okay. You can do active squats or half squats using a chair. You can pick the angle that you want them to go to. You can even have them sit in sort of an isometric position, or you can do eccentrics. I won't do eccentrics with a chair, but I'd rather do them with a TRX band. The person can go down slowly and then pull themselves back up with their upper body so that they're not putting their knee under high concentric forces. You should also be applying exercise to the muscles that attach to the IT band. So clamshells are an excellent exercise. You can place a band across the knees to create some force or some resistance to the TFL and the gluteus medius. You can do some self-resisted knee extensions. You can have them standing and doing some hip abductions. You could also do some glute bridges. You can do this with a ball between the knees to activate those adductors and medial hamstrings. You can also do it with a band around the lateral aspect of the legs to induce some external rotation in the hips as well. You'll notice I've got lots of pictures on these slides. You can go through them yourselves. I'm also going to post videos when it becomes lab time of exercises that you can do for these things as well. You can also provide some specific home self-mobilization techniques. So you can see in this image labeled G, the individual is placing some inferior pressure to the top of the patella. And in the image labeled H, they're doing some medial lateral self-mobilization. This can be very therapeutic. It feels good. It also helps the individual learn to deactivate their quadriceps or calm their quadriceps down while they allow some natural movement in the patella to occur. The exercise labeled K here is called quad sets, and it's an excellent exercise. You don't need this many towels. This is a bit excessive, depending on how much they can bend their knee. But what you're going to ask them to do is you place towels behind the knee and you ask them to drive their knee into the towels. Okay, a lot of times their heel will come up off of the towel. This is an isometric exercise that you can complete for knee rehab. Then you've got what I call the psoas march. This is sort of with a band. If you're using this with a band, you're doing some resisted hip flexion essentially. You can do the same thing just with your hands to resist against your own self-resistance with your knee if you're doing some hip flexion. The next case we're going to look at is a 25-year-old obese male who has pain in their knee, but it's just inferior to their patella. Okay, so it's between that tendon that attaches your patella to your tibial tuberosity. Over the last few months, he's been playing a lot of basketball with his friends. You notice that there's some swelling, some redness beneath the kneecap, and it's very painful to palpation. So touching it is really painful. There's no obvious injury when he's walking around. It's okay, but once he starts to do some exercise or any sort of direct contact is really painful. Okay, the range of motion is full, and after an assessment with yourself and your colleague, you've diagnosed them with, or your chiropractor's diagnosed them with patellar tendinopathy of the left knee. Now, I want you to think, and I know during lecture we talked about this either last week or the week previously. What's the difference between a tendon and a ligament? Think about that. Should this injury truly be called a patellar tendinopathy? The area where this individual is experiencing pain is right here where I'm circling with the cursor. This technically is a ligament, right? It's only attaching the patella to the tibia. There's no muscular component in there. So technically, and I'm doing air quotes here, you can't see since it's an online lecture, technically this is a ligament. So you will hear a lot of people call it a patellar tendinopathy or a patellar tendon strain. Other people will call it a patellar ligament sprain. But when you the complex part is it's essentially a continuation of the quadriceps tendon. Okay, so the quadriceps tendon attaches into the superior aspect of the patella, which pulls on the inferior aspect or the patellar ligament. Just an aside for you to think about. This is very common with overuse or repetitive strain under load. Personally, I find that it's very, very common in people who jump a lot. I get it in basketball players. I get it in, I actually had a gymnast who had this really, really badly. It was very challenging to get rid of. I've got a number of CrossFit athletes who come to see me who have injuries like this. And typically you'll have pain anywhere from the inferior pole of the patella into the tibial attachment. Okay. It's very painful with concentric contractions of the quadricep. Jumping, landing, kneeling, deep squats can be problematic. Typically, I see that unilateral exercises, so lunges or pistol squats, are very problematic for these types of injuries. Okay. Your rehab approach for patellar tendonitis or patellar ligament sprain is going to involve, it's going to be a combination of flexibility and strengthening exercises. Okay, so you're going to address the patellar ligament directly, but you're also going to address all the surrounding muscular tissues. So you're going to have to work on the hamstrings, the quadriceps, the calf muscles, the popliteus. You're also going to have to work on potentially reducing the direct inflammation to the tendon. And eccentric exercises are going to be of utmost importance to start with patellar tendinopathy. Can anybody think of why that's the case? Well, eccentric exercises target the tendon. Okay. We're also stronger in eccentric loading, so it's less risky to be doing eccentric work. And as you start to target the tendon, it allows for reduction in swelling because of something called the GAG or the GAG protein that stands for glucosaminoglycans, I believe. And the glucosaminoglycan protein, it's a significant pain generator, and it also generates a lot of inflammatory agents in tendinopathies. So by doing eccentric exercises, you can reduce sort of those inflammatory markers. It's actually quite relieving. And if you've ever had an injury like this, concentric exercise is actually very painful. So even when you do start to incorporate concentric exercise, you're going to do it on a very slow, sustained, low load profile. Okay. So once you eventually progress to loading in, say, a squat or a lunge, it's going to have to be slow at a consistent pace, and not overloading the tissue. Here are some common exercises that are prescribed for patellar tendinopathy. You've got essentially eccentric squats, double leg or single leg. You can obviously give them a declined standing board or a declined stool. What this does is it allows for more increased loading to the quadriceps. It's also going to be a little bit more relieving for the ankles, because really you're trying to address the knees here. You can do some squats, assisted or otherwise. You're going to want to stretch the quadriceps and the hamstrings, and you can use all sorts of interesting banded exercises, and you can check these out on Hep2Go or Physiotech if you have access to it. This is one of my favorite rehab exercises. I use this a lot in knee pain patients, especially anybody who's got post-surgical care. You will not give this to them right away, but this is one of my favorite eccentric exercises. And it's called a Spanish squat. There's two ways to perform this exercise. And this is one way where you're holding in a very isometric position. Okay, so you're holding a squat. You know what? I might demonstrate this during lecture, because there's two ways to actually do this exercise. This is one. This is a very specific isometric hold. The band is applying an anterior translation to the tibia in order to kind of strain that patellar tendon. You can also do this where you're standing up and you start with the knee a little bit flexed and you actually extend it maximally. So you are isometrically contracting maximally your quadricep in a knee extension position, and it will load the tendon. I find that's a great facilitating exercise before you start to engage in, say, squats or lunges or anything that's going to stress the quadricep to a high degree. Okay, please remind me during lecture to review the Spanish squat, and we can go through that next week. This slide has some other exercises that you can do. Heel taps is very, very important. Again, you can go very slowly. You start in this position standing on a stair, and then you lower yourself down, tap the ground, and you can either concentrically ascend back up, or you can step down, walk around, stand back up if you're just working the eccentric phase of this exercise. Clamshells, of course, are going to be helpful. And then as you can progress to any sort of strengthening movements, it's very helpful. Again, strategically use your eccentric and concentric loading. So start this exercise eccentrically. Start in this position here with your knees fully extended. Eccentrically load the quadriceps tendon, maybe over 5 or 10 seconds, and then you can have a spotter push that weight back up. The next case is an IT band syndrome. So you've got a 32-year-old fit female triathlete who presents to you with pain along the lateral aspect of the left knee and hip. It's aggravated only when she gets about 5 kilometers into her run every day. Okay, she's been steadily increasing her weekly mileage because she's got a race to run in a few months. And she keeps getting this snapping over the lateral aspect of her knee, which at first was just a noise, but it's now quite excruciating every time it happens. She reports intense pain when she foam rolls her quadriceps, her IT band, and you are expecting, or you sort of suspect that it's irritation to the IT band. because there's tightness in the glutes, there's tightness in the TFL, the tensor fascia lata, and she has some pain with that foam rolling. So again, this slide rehashes the primary function of the IT band, which is to transmit forces from the hip down the lateral aspect of the thigh to the knee. Okay, it's the attachment site for many muscles. And personally, when I see lateral knee pain and I've ruled out that the LCL isn't the primary culprit, I'm working the IT band, yes, but most of my treatment's going to be at the hip. Okay, I'm trying to work through that gluteus medius, gluteus maximus, the tensor fascia lata, any sort of contributing factors from the vastus lateralis, any sort of contributing factors from uh, from the hamstrings as well. So it's going to be important to teach some home exercise programs to anyone with IT band issues, and you're going to teach stretching. Okay, so you want to stretch the IT band, you want to stretch the hip flexors with the lunge maneuver. You're going to do the adductors through a butterfly or standing lateral lunge. The hip abductors are going to be important, so stretching out the gluteus medius, the probably the piriformis and the glutes as well. The tensor fascia lata, you can do this sideline. You can also do this laying on your side as well. You will also want to focus on strengthening the posterior lateral hip complex. So glute bridges, clamshells, monster walks, these are sort of a mainstay. These are my personal favorite posterior lateral hip strengtheners. You can also do supine or sideline knee abduction and adductions. You can do some bird dogs. You can do skater strides, which are another one that I'll often incorporate with these three. You can do those banded, or you can do them without bands. And wall taps are another great exercise. So wall taps are right here on the upper left side. The skater strides that I mentioned, that's when you wrap a band around your feet, similar to this monster walk, but when you keep one foot in place and you posterior laterally abduct your other hip on a 45-degree angle backwards, as if you're applying a skating stride. Okay, great for strengthening those posterior lateral hip muscles. Gives you a really good burn after you do them. You can also do sideline hip abductions that you see on the bottom of the bottom right side of the slide here. These can be done with the feet facing straight forward, or you can rotate the hips so that you're getting some hip abduction or not abduction or adduction, internal or external rotation at the hip. So we have a very, I'm sure you can understand through our discussions of the hip and even today as well, but you have a very robust lateral hip complex that's responsible for abduction and extension and flexion at the hip as well. So I want to expose you to this really cool study. This study essentially asked if all hip abduction exercises target the muscles of the lateral hip equally. Okay, so we're looking at the muscles, the gluteus medius, the tensor fascia lata, the gluteus maximus, and the hip flexors. Okay, when you do hip abduction exercises, are all of these muscles activated in a similar fashion? Okay, so what this study did is it set up participants with EMG. So it measured the EMG activity of the gluteus medius, the TFL, the gluteus maximus, and the hip flexors. Then it ran the participants through 3 hip strengthening exercises. So it looked at sideline hip abductions, with external rotation of the hip, and clamshells. Okay, so 3 similar but slightly different exercises. Then it compared the EMG activity, or the muscle firing activity of each of these muscles throughout these 3 trials to see which exercise actually selectively activates one or two of these muscles compared to the others. What the results found is that the greatest gluteus medius activation happened with strict abduction. So with the feet facing straight forward and a hip abduction movement happening. That's this movement here on the bottom of the slide. Clamshells are this exercise here on the bottom left. And the hip abduction with external rotation would be if this individual had their foot fully externally rotated, that's creating an external rotation at the hip. Okay? So with strict abduction of the hip, you had minimal activation of the tensor fasciae lata and minimal activation of the hip flexors. Okay. Now, when you look at the other two exercises, so abduction with external rotation and clamshells, you had higher activation of the tensor fasciae lata and the hip flexors. So if you have done an assessment and you identify that somebody's gluteus medius is inhibited or weaker, you know what exercise to use. If you've done that assessment and you notice that their tensor fasciae lata and say their glute max are problematic, then you know you should be using abductions with external rotations and clamshells. Just an interesting study. Most exercises that strengthen the hip complex are going to utilize either free weights or jumping or resistance bands. So resistance bands are a huge portion of the rehab with the lateral hip. My question to you is, where do we put that resistance band? Where is it most optimal for providing the most resistance? Is it better to have it around, say, the hips, towards the groin, or towards the knee? Is it better to be below the knee? Is it better to be just above the ankles, or even on the feet? What is the best place to put that resistance band? And the true answer is it really depends. Okay. In general, the further away it is from the hips, the more resistance, because that increases the moment arm, and the more challenging that exercise is going to be. Okay. So a band that's wrapped around the feet is going to create a larger moment arm or a larger torque arm, and it's going to require more force to resist the band. Okay. So as you progress with somebody's exercise routine, you may start up closer to the hip. As they get stronger and more able, you might move down to the knee, and then below the knee, and then at the ankles, and then around the feet. Okay. Research has shown that bands that are wrapped around the forefoot tend to activate gluteal muscle activation more than the tensor fasciae lata. Okay. Our next case involves actually it's two cases. We're going to look at the ACL, or the anterior cruciate ligament. So the first case is more of a worker injury. So you've got a 40-year-old male who works in a delivery truck. He jumped out of the truck, landed on the ground, and twisted at the knee while he was pivoting. So he reported feeling a little pop. He went and delivered the package to the front door, and he had immediate pain, especially when he went to put any force on it after he had sat in his truck for a couple of minutes and had to do the next delivery. Okay. He went to a local clinic and was diagnosed with an ACL sprain, grade 2. Another case, similar but different, is a 28-year-old male football player was running to catch the ball. They landed on their right foot, pivoted, heard and felt an immediate pop, fell to the ground, and had no ability to weight bear on that side. So they were carried off the field. They went to the sports med specialist, had an MRI, and was diagnosed with a complete ACL tear. So there was a tear directly through the ACL structure. Very unfortunate, but also unfortunately common. I want you to take a minute or two to watch this video. We're not going to do it right now because I don't know how that will render rewatching a video, but I'm going to leave you the link here in the bottom right. This is a great video that shows how non-contact injuries and a plant and pivot can cause an ACL tear. The ACL is a fascinating ligament. It's one of 6 knee ligaments that provide stability during the articulation. And its primary function is to restrain anterior translation of the tibia in relation to the femur, which I've mentioned already. It also prevents hyperextension of the knee joint, and it's particularly vulnerable in sports like soccer, football, anything where you've got constant directional changes. You've also got significant loading. So if you're running to a ball, you have to plant your knee and then you're rotating your body to make a kick. That is a lot of strain to the cruciate ligaments. So it's very prone to injury in those sports. The structure is actually triangular in nature. So this means that it's thicker at the ligament bone junction and it's thinner along the middle aspect. So it's tapered along its length. Okay, so along the midsection, it's very thin, and that's where it's very prone to rupture, is at this midsection of the ACL. Unfortunately, the vast majority of ACL tears will result in osteoarthritis development over time, and up to 15% will require a total knee replacement. And this is because once you have an ACL tear, there is going to be some laxity. So there's some movement that shouldn't be occurring at the knee, and that can lead to the development of knee osteoarthritis. Given this picture on the slide and this cadaveric knee, you can see how smooth the surfaces are on the knee joint. It's quite amazing, really. And you can see the ACL here that's been torn. PCL would have been torn here as well. And you can see just the outer rim of the meniscus, which is appreciated there. One of the primary mechanism of injury for an ACL injury is when the knee is in slight flexion up to about 30 degrees, or when it's extended with valgus rotation. So typically it happens with a cutting or pivoting maneuver, and sudden deceleration with when the foot is planted. What I want you to do is, if you have the time, look at this article. It's one of my favorite reviews on the biomechanics of the ACL. And it looks at what materials can be used for reconstruction. It also provides you with some ACL injury prevention protocol and it discusses typical surgical interventions. So it is rather important to understand the difference between contact and non-contact ACL injuries. Okay, non-contact ACL injuries are more common, and these are the injuries when you have somebody running, planting their foot, and making a turn. So there's no physical contact. Contact injuries are, let's say, in football, if somebody makes a catch and then they make a catch really high and they get tackled really low, and this might cause unnatural rotational forces onto the knee, can cause an ACL injury. So non-contact is actually much more common than contact injuries. The research suggests that when you land on the ground with your knee flexed greater than 30 degrees with valgus collapse, that is what stresses the ACL. It also stresses the MCL, so the medial collateral ligament. This position is typically what will cause that unhappy triad of the ACL, the MCL, and the medial meniscus. You get tears in all three. Anybody I've seen with an unhappy triad typically will have surgery, and then you're dealing with post-surgical care with the individuals. The Moon guidelines, I've given you the reference here. Please look this up. This is really, really cool rehab guidelines. It's post-surgical care, and it outlines exactly what your goals should be. It also gives you suggestions for exercises. So after surgical ACL reconstruction, we want to look at early return to weight bearing. We want to sort of get passive range of motion back to normal as quickly as possible. And there are sort of benchmarks that you want to obtain. You want to gain back neuromuscular control, and you want to start open chain quadriceps activities within 6 weeks post-op. That doesn't mean you should start it at week 1. That means you should hit all of the benchmarks getting up to week 6 and then start to incorporate those open chain exercises. If individuals have a partial tear, a lot of times they will not undergo surgery, and there is non-surgical rehabilitation um, protocol as well that you can find for ACL injuries. The next case that we're going to look at is a PCL injury. So, while working as a sideline medic at your local youth hockey tournament, you assess a 14-year-old boy who went directly into the boards at full speed. They had their hip and their knee flexed. The tibia hit the boards. The tibia went directly into the boards, and the patella was just above the ledge of the boards where the boards meet the glass. The athlete felt an immediate pop, had pain, couldn't weight bear, and you pulled them off the ice. You got them to take their shin pads off, and you did what's called a posterior drawer test. And you notice that there is some laxity in the knee. So you've asked them to go to their family physician. Their family physician has referred them back to you and has written you a note that suggests that there is a PCL tear in the knee. PCL tears, as I've mentioned, are rather rare in isolation. I've really only seen them in those 2 specific mechanisms that I've mentioned before. And they're noted here again on this slide. But they only make up 20%, less than 20% of cruciate ligament injuries. So ACL is much more common to tear. The PCL is actually supported by the quadriceps. So if you think about it, the PCL prevents posterior translation of the tibia. The quadriceps also resists posterior translation of the tibia in relation to the femur. So it is supported by a larger muscular system as well. Now, regardless of if there was surgical intervention or not with an ACL injury, you're going to focus in order regaining range of motion. Then you're going to look at regaining strength in isolated planes, so flexion extension. Then you're going to look at proprioception and stability as sort of late stage rehab. As I mentioned previously, there's a number of post-surgical and non-surgical rehab. And I've given you a couple resources here. You've got Fowler Kennedy, which is a fantastic institute associated with Western University. They are kind of the gold standard in Canada for a number of knee injuries, arthritic and otherwise. And then the Massachusetts Sports Medicine Institute, they've also given excellent rehab protocol for the ACL as well. Okay, and this is a very, very typical look to a rehab program where it gives you considerations at the top, depending on if it was an allograft, so a graft from the person's hamstring, or if it was from somewhere else. And then they will break it down into phases. So phase 1, immediately post-op, 0 to 2 weeks after the surgery. They've given you goals. You want to protect the graft, reduce the swelling, restore patellar mobility. I'm not going to go through everything here. Then you want to progress to weight bearing and any sort of interventions that you can use in the clinic using ice, compression, elevation, ankle pumping. You can follow it literally week by week on how you should construct your rehab for these sorts of injuries. A lot of the exercises contained in the next few slides are involved in those protocol. And so typically right off the bat, you're going to want to reduce their pain, their swelling. You're going to want to encourage very, very small, small movements as soon as you can. Likely not right away after the surgery. You're going to focus on your peace and love concepts, which we'll discuss. Peace and love is strategies for caring for injuries in the acute and the chronic phases. You're going to want to encourage weight bearing, some gentle heel slides actively, which you see at the top right side of the slide here. You can also do passive heel slides, which is seen on the bottom. And once you do weight bearing, likely with some support from a chair or a door frame, you can have the person stand on their good foot and slowly start to appreciate a little bit more weight on the surgical side. Okay. You're also going to want to look to restore patellar mobility and give the individual lots of education about what they can do at home and what they can expect in terms of their outcomes. After the immediate phase, again, you're going to want to teach some self-patellar mobilization. You're going to want to start to work on the calf strength and stretch the hamstring. ACL is this interesting surgical procedure where they can take a graft from many different locations. So they can take it from the hamstring, they can take it from the patellar tendon or the quadriceps tendon. So you need to be cognizant and careful depending on where they took tissue from, because there's going to be injury to that tissue as well. In terms of strengthening, you're going to start with seated open chain exercises first. You can do some seated calf raises, some knee extensions, some leg curls, and then a little bit of hip strengthening as laying down, but again, non-weight bearing. As you progress with the rehab, so say whatever it may be, weeks 8 through 12, you might start to do a little bit of cardiovascular exercises. You might be doing more strengthening. So you're going to want to add ankle weights to the existing exercises. You can incorporate a little bit of leg press with very, very light weight. Some step ups and some heel taps. You can do that in the sagittal plane. You can do it in the frontal plane. You're going to want to do some glute bridges, some planking. And then once you get past sort of the midterm or the mid-stage rehab, you're going to want to start to incorporate some proprioception and some balance work. So with proprioception and balance, we're looking at balance on 2 feet. We're also looking at balance on 1 foot. And again, this is progressed rehab. So this is late stage recovery. So you're going to look at single-legged stance on 1 foot. You can do things on a rocker board or a wobble ball. You can also do what we call star excursions, where the person uses their foot and they stand on the knee that was, say, injured. You can do this with a bend or without, depending on how early stage rehab you are. And they'll touch the 12 o'clock, the 3 o'clock, the 6 o'clock, the 9 o'clock, 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock, and it puts differential forces onto the knee. So again, that's that star excursion that I just mentioned in the last slide. Once they've mastered that, you can make it a little bit more challenging. You can get them to stand on, say, a towel or a pillow or something like that. You also will want to do more dynamic joint stability. So some step ups, some step downs. You want to do some squatting using a flat surface, a declined surface, wobble boards, trampolines. And then to make things more challenging, you always want to change the plane that they're working in. So they can do lateral lunges, frontwards lunges. You can change the speed of the movement. You can change the number of repetitions of the movement. You can change their feedback and the amount of feedback if they get visual feedback or proprioceptive feedback. There's lots of different things you can do. I really encourage you to check out those resources from a few slides ago from Fowler Kennedy and Mass Sports Medicine. And as you're leading up to return to sport and engagement in activity, you're going to start to do exercises that really do strain that new ACL reconstruction. Okay. This is where you start to incorporate some running, some jumping, some plyometric activities, and sport specific work. So you can do 2-legged jumps, 1-legged jumps. You can do agility drills where people are running forwards, backwards, medial, lateral. Change of direction. You can do work with cones and some shuttle runs. You can get very creative with sport-specific exercise. If there are any questions about knee rehab, please feel free to ask me during our next webinar. The final section of this lecture is going to discuss outcome measures. Remember that you can use the lefts The left is the lower extremity functional scale, and it's a general scale for any lower extremity issue or dysfunction. Okay. We discussed it with the lecture regarding the hip. It's applicable to the hip, but it's also applicable to the knee, the ankle, the foot, and everything sort of in between. So you can always use the lefts. The KUS that stands for the Knee Injury and Osteoarthritis Outcome Score. And this is specific to the knee. Okay. And even more specifically, it looks at short and long-term disability in relation to knee osteoarthritis. And it assesses 5 outcomes. So it looks at pain, symptoms, activities of daily living, sport and recreation, and knee-related quality of life. Okay, so it is rather all-encompassing. And I'm going to, this is the questionnaire. It's rather simple to go through. It's great. It looks at symptoms in terms of these 5 areas, and it's easy to run patients through. It only takes a few minutes. So I will put a download. I'll put a copy of this on Canvas, and you can access it and go over the measure yourself. Okay. So that's all I had for you for today. I hope you enjoyed this lecture. Hopefully there's some Leaf fans out there who know who this is. I will post the references and the KUS questionnaire so that you can take a look at it at your earliest convenience. Okay. Have a fantastic day, and I will catch up with you during our next lecture.